Blog Talk Radio.
Welcome to today's episode of M-Patient Myeloma Radio, a show that connects patients with myeloma researchers. The goal of this series is to help you understand that your participation in clinical trials matters. We now have heard many times that yesterday's trials are today's therapies. I started this series because I had to ask myself, how long do I want to wait for a myeloma cure to be found? And what can we do as patients to move that discovery forward faster? There was a lot we can do besides donate to a foundation, although that is a great option, but we can join clinical trials. So that, of course, is my cheerleading for today. I encourage you to sign up for our M-Patient Minute newsletter, where we post our upcoming show and our past interview in a weekly email. You can do this on our homepage, www.mpatient.org, where you will find links to our Twitter and Facebook pages as well. So we encourage you to tell your myeloma friends, and because it's a great way to hear what is happening in myeloma all over the world. So I'm very happy and delighted to be having a conversation today with Dr. Van Rhee of the University of Arkansas for Medical Sciences. Welcome, Doctor.
Thank you for having me on the show.
Oh, thank you for joining us. We feel so excited. The UAMS program is very well known, and I'm very happy to be discussing your research at the largest U.S. center with a single disease focus on myeloma. And I'd like to share a short profile of you for our listeners, if that's okay.
That is fine.
Dr. Van Rhee is a professor of medicine and director of clinical research with the Myeloma Institute for Research and Therapy at the University of Arkansas for Medical Sciences. He earned his MD at Erasmus University of Rotterdam in the Netherlands and his PhD at the University of London. He was a fellow in hematology and a research fellow at the Hammersmith Hospital and Royal Postgraduate Medical School in London. He was also a registrar fellow in hematology at John Radcliffe University Hospital at Oxford and at the University Hospital in Nottingham. Dr. Van Rhee's research focus is on immunotherapy. He leads the Developmental Therapeutics Project in the Myeloma Institute's PO1 grant called Growth Control in Multiple Myeloma from the National Cancer Institute. He's a member of the International Society for Experimental Hematology, the International Society for Cellular Therapy, and the European Group for Bone and Marrow Transplantation. He's on the editorial board for Annals of Hematology, Bone Marrow Transplantation, and Cytotherapy, and he reviews for many journals, including Blood, Clinical Cancer Research, and the British Journal of Hematology, and many others. So, Dr. Van Rhee, we are very privileged to speak to you today.
Yes, I'm very happy to be on the show.
Would you like to start by giving us kind of an overview of total therapy and where it's headed?
Yes, we started total therapy back in 1989. The idea of total therapy is to apply all available drugs up front, in an attempt to cure the disease. The approach was actually modeled on the treatment of childhood leukemia. In childhood leukemia, induction chemotherapy is used to bring the disease under control. Then there is consolidation to further start to reduce the tumor burden, and then there is maintenance to eliminate any remaining cancer cells. Using that approach, developed at St. Jude's Children's Hospital in Memphis, the cure rate in the 1970s and 80s was only 5% of childhood acute lymphoblastic leukemia. Currently has risen to over 90% with the total therapy approach. So enormous progress has been made. And our total therapy approach really has been modeled on that. So we use combination chemotherapy to reduce the disease burden. And then the melphalan transplant is a way of getting the patient in remission. Typically, one melphalan transplant gives you a remission rate of 20%. And the idea of doing two came also from the St. Jude's observation that when they achieved a complete remission rate of 40% in their patients, that they saw patients being cured. So we had early on a very simple idea: let's do 2 transplants, we get a complete remission rate of 40%, and maybe we'll be curing some patients. In the early days, we had maintenance with drugs like dexamethasone, interferon. We later discovered thalidomide here. We added a consolidation and then maintenance with thalidomide. And in Total Therapy 3 versions, we started introducing drugs like bortezomib and thalidomide and Revlimid during the treatment program. So we've made enormous progress in patients which we call standard or good risk. We separate patients based on gene expression profiling. So what we do is we take a bone marrow sample, we select the myeloma cell, and we look which genes are overexpressed and which genes are underexpressed. And using that method, we can get a molecular picture of the disease, and we can separate the patients into 2 groups. One group at diagnosis is 85% of patients have standard or good risk disease, and 15% have what we call high risk disease and have an increased risk of relapse. Both groups of patients go with equal ease into remission, but the high risk group has a bigger risk of relapse. Recognizing that, we are now treating the patients with high risk disease on a different protocol. So we're presently the only group which assign treatment to patients based on the genetic picture of the disease.
And I think we'd love to hear what you do for the 2 different groups.
At the moment, we're getting very good results with the standard or good risk group. They get 2 cycles of induction chemotherapy, 2 transplants, about 3 months apart, 2 dose reduced, what we call consolidation, and 3 years of maintenance with bortezomib, lenalidomide, and dexamethasone. Then the high-risk patients we approach differently. We think that many of these patients have very rapidly growing disease, and we try to shorten the treatment-free intervals. In non-Hodgkin's lymphoma, a German group has pioneered using chemotherapy given more closely together in aggressive lymphomas and found better outcome there. So what we do is we give these patients chemotherapy on a 6-weekly basis. The chemotherapy and the transplants are even closer together. So, and the transplants are of lower doses than for the good risk patients. So we give treatment actually more frequently, but when you calculate the cumulative drug doses, they actually get less total amount of chemotherapy. The idea is to continue to give chemotherapy and to prevent regrowth of the tumor. If you do 2 transplants 3 months apart, you can already have regrowth of the cancer cells. So we rely on drugs working together, which we refer to as synergism between drugs, and applying the treatments frequently in order to continue killing the cancer and preventing regrowth of the myeloma cells. Paradoxically, although we say we give more intense chemotherapy, the regimen, because we give less cumulative chemotherapy, is actually, it's not a tough treatment program for the high-risk patients.
Is there any age kind of restriction that you have, or no, it's tolerable for everybody?
Well, tolerability is obviously determined by the fitness of the patient, and to some extent also by age. But our frontline protocols are designed for patients up to 75, and whether somebody can handle a more aggressive treatment program is determined to some extent by age and obviously also by the presence of other medical illnesses.
Well, let me ask a question that sort of backs up a little bit, because when you're talking about gene expression profiling, I know this test came out of UAMS and is not available to everybody. I was at a patient conference where I kind of asked everybody to raise their hand to see if they had this test done, and only about 10% of the people had this test done. So can you help us determine, beyond the different translocations, does it determine that, is that the test that determines the translocations? Because I know some of that is coming out of the cytogenetics test and the FISH test, and can you kind of explain that for us?
Sure. We're talking really a little bit about three different tests here.
Okay.
The first test is called metaphase cytogenetics. What you do is you put the myeloma cells in culture, and when they're dividing, you can actually see the individual chromosomes under the microscope, and you can see whether there are abnormalities there. In our hands, about 30% of patients will have abnormal chromosomes visible. In 70% of patients, the test is not informative, and the reason for that is that the myeloma cells cannot grow outside the bone marrow, so they need the support of the bone marrow to grow. It means that these patients have less aggressive disease. So the advantages of the metaphase cytogenetics is that you identify the patients with more proliferative, more aggressive disease, and you can look at all the chromosomes under the microscope. The disadvantage that it's not informative in 70% of patients. The FISH test, which has especially been promoted by the Mayo Clinic, is you look at certain hotspots on the chromosomes, and you look with specific probes. So you can, for instance, see whether chromosome 4 and 14 are linked together, which is a not uncommon abnormality in myeloma. So the FISH tests you can do on resting myeloma cells. They don't need to be dividing in test tube, and it's informative in all patients. The limitation is that you can only see what you look for. In other words, there are a limited set of probes and a limited set of abnormalities which can be looked for. So again, the advantage is informative in everyone. Limitation is that you can only see what you look for. The gene expression profiling is actually commercially available, and again, you purify the myeloma cells and you extract the genetic material, apply it to a chip, and you can see which genes are on or off, and you get a molecular picture of the multiple myeloma. Based on that, we've recognized at least 6 subgroups of multiple myeloma, and then again, based on the expression of 70 genes which are either highly overexpressed or underexpressed, we can assign patients to high risk or conversely lower standard risk.
Can you identify those 6 groups, or what those are?
Yes, the groups are identified on the expression of 100 genes. 50 are over, 50 underexpressed, and we got a disease group which we call low bone disease, in which the patients truly have low bone disease. Then we got a CD1 subgroup, a CD2 subgroup, the MM6 subgroup, where there's very often translocation for 14. We got a proliferation subgroup, where the patients typically have more aggressive disease with activation of genes involved in the growth of cells. And then we got a subgroup identified by the activation of certain oncogenes, which are called MAF and MAFB. So those are some of the molecular subgroups that we identify. And to make things more complicated, if we then look at our 70 gene model, we find that most of the patients with low bone disease have standard risk. And there's enrichment for high-risk disease in the proliferation subgroup, and to a lesser extent in the 414 subgroup and the MAF subgroup. So it's very complicated. So myeloma, there are a number of molecular subgroups, and then we've got high and low risk disease. So myeloma is really multiple diseases. And there's also an important subgroup which we refer to as the hyperdiploid subgroup, where patients have more than one chromosome, typically of uneven chromosome numbers, that is chromosome 3, 5, 7, 9, etc.
Well, it is complicated, and so it's nice to have someone help us explain it in terms that we can understand.
Yeah. But it's important to understand that myeloma is really multiple diseases, and to some extent you could even say that every patient has a unique disease.
And so, because UAMS probably has a very enviable position, having very long-term data and a lot of it, can you explain how you approach this at UAMS, where I guess how you look at that data, and some of it has to do with databases. I know there are some facilities that it's a challenge, it's just a technical challenge, putting all the data together and kind of subdividing it based on the database that you have, not just the research that you have, but the database that you have.
Yeah, I think one of the uniqueness of our program is that we try to follow all our patients lifelong. So total therapy also means long-term follow-up on our patients. The program here was initiated by Dr. Barlegi in 1989, and we have still patients coming from that era. We make an effort to really follow everybody long-term in order to get an idea of what the long-term outcome is, and also the impact and side effects of certain treatments. We had a trial, a randomized trial initiated in 1998 called Total Therapy 2, where patients were randomized to thalidomide or no thalidomide during their treatment program. And the long-term follow-up shows that differences in overall survival took 8 years to emerge, which is really a very interesting observation, and also points to the need for long-term follow-up patients to discern late-appearing outcome differences. I think the other uniqueness of the program is that right from the beginning, we've been doing the metaphase cytogenetics on all patients, MRI. We started doing PET scanning systematically, starting in the late 90s, and gene expression profiling was added in 2000 to the workup of the patients. So we got a very comprehensive data set on our patients.
And what does the imaging add?
This really pertains to the issue of how you define complete remission. At the moment we say that complete remission is that the bone marrow needs to be clear and that there should not be any myeloma protein detectable in the peripheral blood or urine. Clearly in the MRI we can see that 50% of patients will achieve an MRI remission over time. We also know that the number of focal lesions at diagnosis in the MRI influences outcome. The PET scan is based on a sugar dye which is taken up by the myeloma cells, and you can see hotspots. The PET scan will image the whole body, so you can also detect myeloma outside the bone marrow. We know that the number of focal lesions at diagnosis has prognostic significance. We also know that especially in the high-risk group patients, if you still have active disease after induction chemotherapy on the PET scan, that you have worse outcome. The changes on the PET scan are very dynamic and occur rapidly. So on follow-up PET scanning after one cycle of chemotherapy, you can see very significant changes. Changes on the MRI occur much more slowly, and achievement of MRI remission typically takes 18 to 24 months.
Okay, well, diagnostics is very important, and it sounds like there are multiple approaches.
And the other thing I might add is, since we systematically follow everybody with both imaging modalities, we do see patients where the first sign of relapse is not the reappearance of the myeloma protein or the reappearance of the myeloma cells in the bone marrow, but in fact we see a spot of myeloma growing or several spots on the PET scan or MRI. So we do see that the first sign of relapse can be only detected with imaging studies.
Wow, so how frequently do you recommend that your patients do that?
We typically do an MRI or PET scan after every cycle of chemotherapy or after every transplant. But during the maintenance phase, we follow them every 4 to 6 months, and eventually, once they're off maintenance, they go to 6 monthly and eventually yearly follow-up.
Okay, and I just have a follow-up question. This may be kind of a dumb question, but if focal lesions are a very big indicator, and then someone goes into complete remission, are those lesions able to heal completely that you see on the imaging studies?
That's a very good question. So it depends on to which extent the normal bone has been damaged. If there has been a lot of erosion and destruction of the bone, then the MRI may never look normal again. Obviously, the PET scan is a functional imaging study. It looks at actively growing myeloma cells, and the PET scan can be negative in patients who still have focal lesions on MRI. We have also systematically done biopsies of these focal lesions. In many patients we do not find myeloma. There are patients who still have dormant myeloma cells in the focal lesions. So one of the areas of interest is whether these focal lesions in some patients can be dormant sites where the myeloma can hide, and eventually where relapse may originate from.
Well, while we're talking about diagnostics and complete remission, do you want to talk about minimal residual disease and how you're testing for that?
Yes, I think the minimal residual disease has been especially promoted by a Spanish group in Salamanca, Professor San Miguel, and his specialist there in this area is Dr. Bruno Paiva. He developed a method where he stains the cells with antibodies, and he stains certain molecules at the cell surface, and they run it through a machine called a flow cytometer, and you can see the cells which stain for certain molecules at the cell surface light up, and you can identify them. And this way you can separate normal plasma cells from myeloma plasma cells, and you can detect very small numbers of plasma cells in the bone marrow. Sensitivity can be as high as 1 in a million, which means that you can pick out one myeloma cell in the background of a million normal cells. Studies done in England suggest that if you have no minimal residual disease detectable, that your outcome is better. So this is something that this type of minimal residual disease testing by this test called flow cytometry we've adopted here, and we're doing this systematically on all our patients, and we're prospectively collecting data, and we're trying to figure out what it means.
Now, as I understand it, there's different sensitivity that can be performed on this flow cytometry test, and it has to do with the number of colors that are being run. Can you explain what the significance is of the colors?
We use the 8-color flow cytometry, and every color identifies a different molecule, and more colors will give you greater sensitivity in detecting small number of cells, and you can characterize the cells better. You can detect them better in the background of normal cells. So, in general terms, in cancer, we know that the presence of a few number of cancer cells doesn't necessarily mean that the patient is going to relapse. Early in my career, I was involved in a disease, chronic myeloid leukemia, which was treated at that time with bone marrow transplantation from donors. And we had patients who were in remission for more than 10 years and cured for all practical purposes. We still had a few chronic myeloid leukemia cells detectable in the marrow using very sensitive molecular techniques. And in fact, recently I saw in the clinic a patient who had been in uninterrupted remission for 13 years and still had a positive minimal residual disease test. So we'd like to analyze our data in the context of molecular subgroup and risk, because it may mean different things in different types of myeloma, and that's an ongoing area of research. Maybe in some types of myeloma, it's not that important if you can detect a few remaining cells and it doesn't influence an outcome. And in other subgroups of myeloma, one can speculate that any remaining cells could be predictive of relapse.
Okay, and as I understand it, and this has happened to a friend of mine, after treatment, sometimes that your profile changes.
The genetic profile of the disease can change. Sometimes at relapse, the disease is more aggressive. When we look at our program, when we look at the relapsed patients, 50% have high-risk disease and 50% have standard or low-risk disease. Up front, at diagnosis, 85% have standard risk disease and 15% have low-risk disease. So one of the interesting questions arises how this difference comes about, and we're involved, like many other groups now, doing what is called sequencing, actually sequencing the genes of the myeloma cells, and one can postulate that some patients already have a small number of aggressive, very mutated cells present at diagnosis, and that the treatment clears out the easier disease, and that then the aggressive disease rears its head and causes relapse. In other patients, there might be perhaps still residual disease present, and over time additional mutations arise, and then the patient transforms to high-risk disease. So there are different models on how high-risk disease can come about when the patient starts off initially with low-risk disease.
Interesting. And how do you do the sequencing?
There are different methods. The sequencing can be done of the DNA or of the RNA. We're having both platforms here. One of the things we're trying to do is to identify what is called druggable targets. So we try to identify mutations which may be amenable to drug therapy, which is usually used in other cancers. For instance, we quite often see mutations in a certain pathway, and we can use drugs to treat these patients which are used different cancers.
Well, that would be the low-hanging fruit approach, right? To see what's already available and see if we can use it. So if you were saying that there are 70 genes, that's a lot of genes to try to target, and you're trying to put your data together, and I would think overlap it with each patient type to see if you can find similarities. Have you found certain genes that, like a targeted list of 5 or 10, or have you been able to narrow down the list a bit?
We have been able to narrow down the list. There appear to be 5 genes which are quite critical in determining the outcome, so we can narrow down from 70 to 5 genes and make very similar predictions in terms of outcome.
Okay, and as I know that the testing is getting cheaper and cheaper, should everybody be doing this gene sequencing test?
5 gene test I refer to is done by gene expression profiling, but that test could potentially be set up with a different molecular method and could be done more cheaply and easier. I think the sequencing, which is not only done here but also at other centers, is really in its initial phase, and it will require considerable time to try and figure out what all the changes in the genes mean. So in other words, it needs to be seen in the context of treatment and long-term clinical outcome. So it's very exciting new technology, but it will take several years to try and figure out what exactly the important alterations are and what it means for treatment.
And now, I know that we've heard that maybe up to 10% of myeloma patients are potentially, I say this cautiously, quote, cured, and we don't know, but we think. I'm just curious, who are these people? So what are their profiles?
That's a very good question. When we add other markers, such as the beta-2 microglobulin, which mainly reflects tumor burden, presence or absence of abnormal metaphase cytogenetics, if we add that to the gene expression profile, we can identify subgroups of patients with very good outcomes. When you look at the issue of curability is very interesting. When you look at acute leukemia, you can see that the survival curve becomes flat. In other words, patients don't come out of remission at around 5 years in acute childhood leukemia. We've done similar analyses on our myeloma patients, and it looks like if you are going to be in remission for 10 to 12 years or longer, that we see very few relapses there. So we think that at least in some patients that the disease is curable, and obviously that's good news for the myeloma patients.
Yeah, everybody wants to raise their hand to be in that group. And I think if I could wave a magic wand right now, I would really like to see myself categorized in context. So I could see, for example, I have MAF-B, which is not a great thing, but my cytogenetics might be good, and the other indicators might look really good. So could I find all the patients that look like me and then see what they've done, who's lived the longest, and go backwards? What kind of approach worked for that subtype? I think that's what I would love to see.
When we compare our successive regimens, we can recognize groups which seem to be particularly benefiting from certain drugs. For instance, in Total Therapy 2, we did not have bortezomib in the program because it was not available yet at that time. In Total Therapy 3, we did have bortezomib, and we could see that particularly the patients with a translocation between chromosome 4 and 14, patients with a deletion of a tumor suppressor gene called P53, patients with abnormal metaphase cytogenetics, these were the patients who really benefited from the bortezomib. And that brings us to the next really question, is how we can target our therapies better. In other words, we're trying to figure out who needs what drugs.
Mm-hmm. Absolutely.
For the good risk patients, the goal has to be to make the treatment safer and to target the treatment better. The high-risk patients, I think the way we define high risk, those patients have a much higher relapse rate. We think that maybe in the order of 15 to 20% of patients in the long term of that group of patients might be curable, but they often relapse early. And that's a group of patients which really requires new approaches and new insights and perhaps also new drugs.
Would you like to talk about your where total therapy is now and how you're approaching these two different types in your clinical trials?
Yes, in the Total Therapy 5, we're using combination treatments frequently applied at 6-week intervals, and the patients get 5 of such treatments and then go to maintenance.
Is this for standard or high risk?
That's for high risk.
Okay.
And we are going to introduce in the high risk group in the next few weeks upfront also the new proteasome inhibitor carfilzomib in this particular group of patients. So carfilzomib is a drug which binds irreversibly to the proteasome. The proteasome is like garbage disposal system of the cell. It gets rid of unwanted proteins. Mm-hmm. And if you interfere with that mechanism, the cells will die. So we found that patients who were treated up front with proteasome inhibitor bortezomib, that some of these patients still responded to the carfilzomib drug. So in our hands, it looks like carfilzomib is more potent than bortezomib. Mm-hmm. We also think that there is possibly some more toxicity associated with it, at least in the patient that we've been using it in the relapsed refractory setting, where we see a higher toxicity signal in terms of cardiac side effects. However, that can be mitigated by very careful monitoring of the patient. Obviously, cardiac side effects are much less when it's used up front in patients who haven't been heavily treated.
And in neuropathy, how is it different in neuropathy?
It does not give rise to neuropathy, or rarely. So there is a lot of difference in terms of neuropathy. In all fairness, the administration of subcutaneous bortezomib has made a major impact on the side effect profile of bortezomib, and there is significantly less neuropathy with subcutaneous administration of bortezomib.
Okay. Are there other areas that other clinical trials you'd like to talk about for high-risk patients?
We are using at the moment immunotherapy to try and treat patients with high-risk disease who have relapsed. We use so-called natural killer cells, which we co-incubate with stimulator cells, and then we activate them and expand them, and then we infuse these highly activated cells after chemotherapy into the patient, where they persist, and we see large numbers of these immune cells activating and growing and expanding in the patient. Eventually, they will lose their activity over time. This treatment is very early in its development, and we had to go through a learning curve as how to best make the cells, and we made several modifications in the laboratory in how best to expand them and activate them. So the results are early, and we hope that the expanded NK cell therapy can contribute to the treatment of the high-risk patients. The other area where we're exploring this type of therapy is in patients with smoldering myeloma. Mm-hmm. Smoldering are at increased risk of progression to frank myeloma compared to the benign monoclonal gammopathy, also called MGUS. And based on our gene expression profile, we've identified a group of patients who are at high risk of progression to frank myeloma, and in this group of patients we're also going to explore the expanded NK cell therapy. Obviously, the Spanish have done a trial with Revlimid and dexamethasone, the Spanish collaborative group, and shown that in some patients with high-risk smoldering disease treated with Revlimid and dexamethasone, that it delays progression of the disease and improves outcome. So there is a debate in the myeloma community towards whether we should treat early high-risk smoldering disease earlier. The standard of care thus far has been and still is to observe these patients carefully. But there are a number of clinical trials ongoing now where these patients are actually being treated early, and to see whether the outcome is better with early intervention in high-risk smoldering multiple myeloma. And
so what is your opinion so far? you're not running trials currently, right? For smoldering myeloma, for that, or no?
Except for the expanded NK cell therapy. Immunotherapy. That's the only trial which we currently have open. We're planning another one with a monoclonal antibody. But as such, there's an increased interest in the myeloma community in treating high-risk smoldering disease earlier.
And could you take a minute and just give us a quick explanation again of NK cells, and then what's the difference between a regular NK cell and an expanded NK cell?
Okay, an expanded NK cell is highly active, so it kills the tumor cells much better than a resting NK cell. The other aspect of the activation is that it induces the NK cells to multiply. So once we grow them in the lab, we expand the numbers of NK cells, so you have more NK cells to attack myeloma cells. And after infusion into the patients, they continue to expand for another 7 to 10 days. So you get cells which, one, have more activity and can kill the myeloma better, and secondly, they continue to expand in the patient.
And how do you get them to expand?
We incubate them with a special stimulator cell, which expresses at the cell surface a molecule called interleukin-15, which is a growth factor for natural killer cells, and it also expresses a molecule called 4-1BB ligand, which further stimulates the activation of the natural killer cells. This particular stimulator cell was developed by Dr. Dario Campana at St. Jude's Children's Research Hospital, and he has an interest in treating, obviously, childhood acute lymphoblastic leukemia with this, and he was so kind to share these cells with us, and we've adopted this technology to try and treat multiple myeloma.
Well, I think the whole area of immunotherapy is so exciting. And this is where your background is, so.
Correct. I think there are a lot of interesting studies in the solid tumor area where one can show that monoclonal antibodies, which take the brake off the immune system, can actually induce responses and sometimes even remissions in patients with solid tumors which were otherwise not salvageable. Obviously, solid tumors are much more frequent than the blood cancers, so the pharmaceutical companies understandably have focused initially on the development of these antibodies in the solid tumor arena, but trials are now starting to emerge also in multiple myeloma. It would be very interesting conceptually to combine these antibodies with drugs which stimulate the immune system. These are the immunomodulatory drugs, which we refer to, drugs like Revlimid or lenalidomide and the newer version, pomalidomide. So I think there will be a lot of exciting studies forthcoming in the future with immunotherapy.
And what phase is your NK cell study?
This is what we call a phase 2 study. So there is an efficacy endpoint. So far, the cells certainly have been safe. We've not seen any side effects.
Yeah, I think that's the beauty of immunotherapy, is that you're using your own system to try to fight these cancer cells.
That's correct, yes.
Are there other trials that you'd like to share with us that you have open?
We're obviously also using the oral proteasome inhibitor, which is a newer version of bortezomib, which is more convenient for the patient. And we also have an interest in using placental-derived stem cells to treat patients. One of the side effects of some of the therapies that we give is a disease called myelodysplastic syndrome, and this arises after treatment, and it's a disease in which the normal bone marrow does not grow well, and there's a risk of transformation to acute leukemia. To the clinical myelodysplastic syndrome, in about 2% of our patients, myelodysplastic syndrome requiring therapy, and we're starting to give placental-derived stem cells, which we think may support the normal hematopoiesis. So that's early in its development as well.
That's great. I just have a quick backwards question, because, and I want to ask you before I forget it. When you say you've narrowed down the 7 genes into 5, can you tell me what those 5 are?
At the moment, it's going to be published, so it will be.
Okay.
It will be out there soon. It's actually under submission at the moment.
Okay. And when you say the immunotherapies, it'll be interesting to see, and I think it will be. How long do you think it will take for us to come to conclusions, or for these studies to show us if those are really effective with myeloma?
I think the highest unmet need in multiple myeloma are the high-risk patients who have a significantly worse outcome, and particularly when we go into the relapse refractory setting, patients who have seen prior therapies and relapse with high-risk disease. I think you can get very quickly an idea whether immunotherapy or other drugs are effective or not. Because in the relapse refractory setting, when patients have high-risk disease, in general terms, their outcome is not good. So it's easy to see whether a drug or an immunotherapy or any therapy makes a difference in that setting.
Mm-hmm. And I think when you were talking about the use of potential therapies that you took from childhood leukemias or other drugs, so this happened with thalidomide at UAMS, taking something that was being treated for other diseases and taking that. Can you share what you think is the ideal process for trying to find these other therapies that might be used right now in lung cancer or prostate cancer or something else, and apply them to myeloma?
Well, the idea is to look for particular mutations for which there are drugs available. So sequencing the genes of the myeloma cells is the way to do that. And that's something that we and other centers are currently adopting. So that's an evolving field. So I think first step is to identify whether the patient has a mutation for which there is a drug available. And obviously the next step is then to determine whether that drug actually has clinical efficacy. So this whole area is very early in its development.
How much does it cost to sequence the genome for myeloma right now?
If you do a limited sequencing, it's probably in the order of $1,000. More extensive sequencing is obviously more expensive.
And does insurance pay for that sequencing?
Some insurances do pay for sequencing. Other sequencing obviously is done on a research basis. So limited sequencing is available from a number of companies in the country.
Okay, well, maybe this might be an area where patients could start to request this.
Yes, the question is obviously first to identify the mutation. Secondly, then get the drug approved, because the drug is used off-label, so to speak. And thirdly, we don't have a good feel yet which of these drugs are really beneficial for the myeloma patient. So there are a lot of question marks and unknowns.
Well, I guess that leads to a follow-up question, and I know we're almost out of time, and I've kind of hogged all the questions, but what can patients do to help you further your research?
We are always very grateful that patients are willing to donate samples for research, both blood samples and marrow cells. And we're also grateful that we can treat the patients and that we can have the long-term follow-up, which is so very important in multiple myeloma.
And how do you do that follow-up? Because I know people move and insurance changes and all sorts of things. So how do you approach that at UAMS?
We try to get everybody back, and if they're many years out, then we try to do at least a yearly visit. There are truly patients in which the insurance changes or they're financially not able to come to UAMS, and those patients we try to follow up by phone and contact them once or twice a year and see how they're doing and get their information for our database. The other thing obviously that we have is for our patients we have a system in which they mail in monthly or 2 or 3 monthly multiple myeloma markers, and then the myeloma protein is looked for in blood and urine, and we try to follow them that way to see whether there's any reemergence of the myeloma.
Well, one final question. What is the significance of, to you, for patients participating in a clinical trial?
I think clinical trials are very important. I think that's the way we find out whether drugs have activity and contribute to improving progression-free and overall survival. And what is referred to as correlative studies, like gene expression profiling and sequencing studies and other studies, allow us hopefully to identify subgroup of patients which really benefit from a specific drug.
Well, Dr. van Rhee, we are so grateful that you joined us today. Is there anything else you'd like to share before we close? Because I know we're out of time.
No, I'd just like to thank you for the opportunity to participate in the interview, and I think patient advocacy is extremely important and powerful in the myeloma field, and has been very helpful both in getting approved and in supporting and informing other patients.
Well, we are very, very fortunate to have you working on the target for myeloma, and we wish you a great deal of success in your care for your patients and in your research. So please let us know as patients if there's anything else we can help you do.
Okay, I will do so. Thank you very much.
Well, thank you so much for joining us. Thank you for listening to another episode of Innovation in Myeloma. Join us next week for our next Patient Radio interview as we learn more about how we as patients can help accelerate a cure for multiple myeloma.
Hello, it is Ryan, and I was on a flight the other day playing one of my favorite social spin slot games on ChumbaCasino.com. I looked over at the person sitting next to me, and you know what they were doing? They were also playing Chumba Casino. Coincidence? I think not. Everybody's loving having fun with it. Chumba Casino is home to hundreds of casino-style games that you can play for free anytime, anywhere, even at 30,000 feet. So sign up now at ChumbaCasino.com to claim your free welcome bonus. That's ChumbaCasino.com and live the Chumba life.
No purchase necessary. VGW. Void where prohibited by law. See terms and conditions. 18+.